Hi everybody, welcome to Nazo Circus. How are you guys doing? I am well in gloomy London town, and today I have yet another exciting guest, and we are going to talk about an issue that's very important now. But let me just let my guest introduce herself, and then we can get to know her a bit better and then go into the story. So, lovely lady, can you tell us who you are, what you do, and I'll ask you a few personal questions. Feel free to skip whatever you don't want to talk about.
Okay. Thank you very much for having me on your show. So my name's Emily Williams Ikpasa. For those who've known me from donkey years, I still also go by my married name as well, Emily Fasuan. And so I'm a registered nurse, qualified, trained midwife as well. I'm also an esthetician, and I'm a clinical informatist. Jesus Christ, I've got so many.
That's a lot. You're wearing a lot of hats.
Yeah, no. So, I've been with the NHS on and off as an agency nurse since the noughties, since 2000. So
Wow.
I'd say with training, I always tell, you need to big up yourself a bit. So,
Oh yeah. No, I'm going to big you up. I'm just waiting for you to, because it's no joke.
Yeah, I've been in it nursing for the past 28 years. That's including 3 years of training, which I'm very, very proud of being a nurse.
Absolutely.
I always say, regardless of anything I do, I'm a clinician first, which I enjoy a lot. It's hard work, but very fulfilling work. I enjoy that a lot. And I'm a mother of 2 young adults and a young adult and a dachshund dog. They got the dog. I'm the one who babysits.
Okay.
Exactly. And so basically that's it. And just generally living a gentle life now. The girls are big now, so I'm basically doing my own thing at the moment, and I'm happy in meeting other people and traveling and doing things like that. Yes. One of my hobbies is photography, and back in the day I did play squash a lot. I loved squash.
Really? Oh my God.
Yeah. But the old bones are all creaky now, so
we will go into the bones right now. We're still rocking our lives. Okay, exactly. So to summarize, so you're clinician, you're a nurse. That's like
yes, I'm a clinician. Yes.
And you've been with the NHS for 20-something years, you said?
Yeah, 20 plus years, yeah.
Let me first of all start by saying thank you, because we here, so I must add, National Health Service, because we're just assuming everybody understands what the NHS is. For people who don't live in the UK, it's our National Health Service. The people in America don't have that privilege. We have the privilege of the National Health Service, and we rely on the National Health Service for pretty much everything. It's free for us, unless we go private. So, Emily, first of all, let me start by thanking you for your service, because here in the UK, we like to complain about the NHS. Meanwhile, we don't know how lucky we are just to even have the NHS. So, I need to big you up. It's no joke. So thank you for that. Can I just ask you a few questions about you? Yes. So were you born here? Were you born in the UK?
Yes, for my sins.
Okay. So you've lived here all your life?
For my sins, yeah. Okay. Well, technically all my life. I did go back to Nigeria. Well, the parents did take me back when I was little. When I was about 6 years old when I went back, stayed there for a few years, came back when I was 12 plus. Okay. And went to boarding school, back to Nigeria when I was just 18, and I came back when I was just turned 21 when I came back. So technically, I've been here all my life.
Basically, okay. Yeah. And so your schooling has been here. I mean, your education has been here in the
England,
UK.
Yes.
Okay.
Yes.
Okay. And so Emily and I met some years ago. It was so funny how we met. We went for an event, and I was at the bar. I didn't really know many people there. I saw Emily at the bar. We said hello. Emily, by the way, You are amazing, because this is another thing that I have with I have with my Nigerian sisters. Sometimes we see each other, everybody be carrying face. I don't understand the carrying face situation.
I don't
You see each other, you're carrying. So we should just say hello. So we said
Hi.
hello, hi. Is this your first time here? We started talking, and we've been friends since.
Yeah.
See how life happens.
Yeah.
Okay, Emily. So we've talked about having this podcast thing for a while.
Yes.
So this is like, I mean, I'm now in my second year into my podcast.
Yeah.
Woohoo!
Congratulations.
Thank you, my love. Thank you. And so my first 2 episodes were about the Japa people. So obviously our brothers and sisters who have had to leave Nigeria to come to the UK in search of a better life, greener pastures. And so I remember us talking a few times about, people that have the Japa community. And the main topic for today is your experience in the health sector, working with our brothers and sisters who have japad from Nigeria.
Right.
So, and what triggered why we decided we must do this podcast today is because of a recent incident where there was a Nigerian health care worker. I think they said she'd only been in the job for like 6 days or something.
Yeah, something like that,
Yeah. And I think she maltreated the guy, the old man she was looking after. And there was video footage. Did you watch that video footage, Emily?
I did. It was horrendous.
It was so difficult. It was so difficult.
Very, very traumatic.
Yeah. So she just wasn't nice. And the guy eventually sadly passed away.
Yeah.
I think they said some days later, 8 days later or something like that.
Yeah.
And I know that now there's serious anger with the sentencing that she got, which people are saying is very light, because I don't even think she got a prison sentence.
I can't remember. It's something very light, like somebody explained it as like a tap on the wrist, and I looked at it again, thought about the implication, and thought about what she'd done, and I thought, nah, she should have gone in.
I think it was a suspended. I may be wrong, but I think it was something imprisonment, but suspended or something. Obviously, that.
It was such an irrelevant sentence.
It didn't match.
It wouldn't impact anything on her as far as I'm concerned.
So Emily, let's get down and dirty into this thing. And this is not in any way trying to bash any of our brothers and sisters in Nigeria, but we've got to talk about the reality of things.
Yes, of course. Yes.
So I think I've had this conversation with a few people where these people, our brothers and sisters from Nigeria who come in, a lot of them even have had good jobs in Nigeria, but they had to sell up everything and come to Nigeria. They come to the UK and they get these jobs as healthcare assistants. Sorry to interrupt. The word you just said, they had. Nobody had to do anything. They wanted to come. True.
They did not have to. They wanted to come. So that one word is kind of like quite big. So, I tend to pick on things like that because, nobody forces you to do anything. You made a decision.
They would probably say to you they were forced because of this. I'm playing devil's advocate here, which is what I always do anyway. They would say because a lot of them say now, they say, I had a good life in Nigeria. I had to leave Nigeria because of the state of the country. Our country is no joke. I couldn't even live in Nigeria if anybody even give me money.
To an extent, I agree with you, but the people living in Nigeria and the surviving, it is hard. Nothing comes easy. The bottom line is fix your country, and the one or two things that, yes, we'll still complain about, but you could live there. People live there and they make it there. It's hard, yes. So there's so many strings to this, but let's go back to what we're
So I guess maybe the reason why they're here is neither here nor there in the context of what we're talking about. So they come here, and because the healthcare jobs come with the certificate of sponsorship, which is what they need to be able to live here legally, a lot of them go for the healthcare jobs. So I think my first question for you is, so you work in the hospitals, right?
Yeah, definitely.
What has been your experience? What have you noticed? Let's start with the positives first.
Oh, yes. The positives, we're always short staffed, so them coming to bridge the gap is quite a good thing. But unfortunately, just like with the NHS, it's just like putting a sticky tape on the problem. However, when you get the good ones, you do get the good ones. I mean, I've worked with Nigerian doctors, Nigerian physiotherapists, Nigerian psychologists, Nigerian all sorts that have had to do the Japa variation, and they've worked here, and we've had good relationships. They've done very good jobs because, I mean, at the end of the day, they're very experienced, I mean, and they study in very, very difficult circumstances. So by the time they come to a softer landing, like, in the West, they're able to kind of like hit the ground running, which is a very, very good thing. And we do get that in nurses as well. I say doctors, but what I mean is clinicians in generally.
Okay. So when you say that, the study hard and everything, are we talking? So we're talking about doctors and nurses, yeah? Because we have different, I guess, levels to this conversation. Yeah. So we have the doctors that were trained in Nigeria and have now come here. I guess they do whatever exams they need to do, and then they get jobs here. And nurses. So those ones are the ones that you're talking about, that you've worked with them, and in your experience, they've been very good ones.
Yeah. Okay. And I'll make an example, and I'll bring it home to myself. My brother is actually a medical doctor, but he's not a japa. He came. He read medicine in Nigeria, and he's been working here for a good over 20 years. Right, but he was technically trained in Nigeria, did his exams, came here to work, and hit the ground running, and he's been here since. So that's what I mean by the doctors and nurses and other clinicians trained abroad, and then they come over here, and they're able to go with the flow and make something of themselves. So,
So those are the ones that were trained, but those are the ones that didn't japa. They came here when they were ready to come here, before the country got worse. So we've dealt with that one, because my sister's a doctor as well. She was trained in Nigeria. She came here, did the extra training, everything. So that's different. Those ones completed everything, did the training. Then we have the Japa community. I don't want to say people, because it sounds a bit like I'm distancing myself. So we have. So let's talk about. So what's been your experience with the Japa doctors and nurses? So the ones that basically left Nigeria because they say they needed to leave because the country is really bad. What's been your experience of those ones? I'm not talking about the support workers. I'm talking about the main,
main qualified clinicians.
Yes.
Okay. So, like I said, I've worked with them. Talking about positive things, they're very, very hardworking. They're not. They really, really get grinding, and they do what they have to do. And you get the ones who are not too sure, and they'll come to you and they'll ask questions, and I love it when I see people like that. I see that they're humble, they want to learn, they want to get into the system with everybody else and fit in. You understand? So when they come to people like us and they ask questions, we should be very supportive to them by teaching them and say, oh, this is the way we do it here. And I've come across so many people like that, I won't lie. I've made a couple of friends with them, and we have good relationships. And but unfortunately we get a lot of negativity as well. It only takes one person to actually spoil the
rest
name,
of it.
and this is what we see now. But they're very, very good nurses, hardworking doctors, physiotherapists, psychologists, dietitians, nutritionists, all of them part of the Japa team. There are a lot of them out there, and they're very, very hardworking, dedicated to their work and learning and doing courses, trying to better themselves, trying to fit into the system and everything.
One thing about our people is that we work hard. We work hard. We want to be the best at what we do, and that rubs some people the wrong way.
Yes, exactly, and that's why. And if you think about it, that is why for an average Nigerian leaving Nigeria, coming to this country, America, Canada, Australia, Austria, Sweden, if you look at the percentage, there are quite a lot of them, and they always thrive. Nigerians actually thrive in a very good environment. Unfortunately, Nigeria has shown not to be a very good environment for them, so they don't thrive, because they're always struggling, fighting against the system and everything. But when they leave the shores of Africa, I'm sorry to say, give Nigerians credit, they actually do thrive.
Yeah, they do. They work hard and they want to be. So that's the positives. So we're talking about the clinicians, what's been your negative working with the clinic? The same. What's the flip side? What's your experience?
So the flip side of this is what I've come across, what I've read, what I've seen, some that I've worked with, we also have an attitude problem as well as Nigerians, of I know it all, or
ITK, we call it I too know.
I too know, exactly. And some of them lie, and you can actually see that they're lying. They don't know what they're doing. I mean, I had a lady one. This was years ago. Still during the Japa thing, I went and did a shift, and it was one of the hospitals where I worked. So they knew me there. So as an agency nurse, usually everybody tries to pull rank and everything. But when you get to start working, then they kind of like leave you to do your thing and everything. So I got my patients and everything, and I was to work with this girl because it was a busy night. So instead of having 4 cubicles to a nurse, we ended up having 6 cubicles. But you either get a care assistant to work with you, or you get a junior nurse to work with you. So you're kind of like, in a way, supervising the junior one if you like. But, you will still, So I got this girl working with me. I got there. She saw that as, black lady, like, and everything. So she was trying to buddy up with me. So I got sorry, and that's all right. But I now noticed that she was doing things that I didn't necessarily agree with.
So was she a junior nurse? Was she also?
She was actually a junior nurse.
Okay.
To be honest. But we were both. No. She was a junior nurse, but she was permanent staff, and I was an agency nurse. But I worked there for so many years. I knew all the sisters, the matrons, everybody. So when I come in, they just say, "Look, Emily, that's your. Give me a handover. Give me my cubicles, and let me get on with it." But they assigned her to me, so we worked together because we got 6 cubicles, whereas usually on a normal day you would have only 4 cubicles. This was an accident and emergency.
Oh Lord.
So anyway, so I now realized that even though she was new, she was one of Japan, she was new, and I realized that she didn't know what she was doing, because when the patient comes in, you get a handover. The patients come in, patients come in. He has pain. You have this, is that. So you get the handover. Then automatically, with the scenario they've given you, you have things to do, steps to do. So usually they come in, you do a set of observations on them. You take the blood pressure. You make sure that their oxygen saturation is fine, the blood pressure is fine. If there's anything that disturbs you, you might take a note of it. So there's something that we do in nursing. We call it a PI. So it's assessment, planning, implementation, and evaluation. So what it means is that you assess the patient, you plan the patient's care, then you implement the plan of care, and then you evaluate the outcome of the care
of what you've done.
So yeah, exactly. So with all this, you always report to either, if you know the doctors around, you can go to the doctor and goes, "Oh, this patient is in pain, can we give the patient something to at least relax and everything?" You understand? So sometimes the patient, doctors look at scenario and goes, "All right, let's just give the patient the most basic pain relief, which is either paracetamol by tablets or intravenously, or an injection." It depends, you understand? Or if there's no doctor there, you now go to your nurse in charge for the shift that day, and you say to the nurse, because some of them can prescribe, some nurses can prescribe as well. So you just go to the nurse, "Oh, I need some painkillers for this patient, and she goes, "All right, then fine, you go and give the patient some paracetamol, I'll sign for it." Because if they're prescribed, they can sign for it, or get to a doctor quicker than you would to sign for it. So that's the first step before, as you carry on patient care. So with this particular nurse, and I realized that, she came in, we got this handover. She wasn't doing the basic things, you understand? And this patient had a head trauma. So you do something called a Glasgow coma score, right? Which is like somebody with a stroke or head trauma, you understand? So there's a level that we can, if it's at a certain number, you can kind of like, you keep an eye on it, like, and everything. So I now asked her, because when you did the assessment, did you do the GCS? She didn't know what a GCS was. So I said, "Okay, fine. Did you do the Glasgow coma score?" She didn't know what it was. And I said, "Okay, come with me." Then I did it on the patient. I was, "Okay, this is what you checked for." So, and then sometimes you have to check it like every 15 minutes, every 30 minutes, it depends on the scenario you're given. But common sense will tell you when you're looking at your patients, because the patient can flip just like that. So common sense will tell you how often to do it. So you start at 15, 30, 1 hour, but you have to do it regularly, and you have to fill it in the observation chart. So like an hour later, I now went to the observation chart. apart from the one I did, she didn't do another one.
So there was no follow-up. Oh, dear.
There's no follow-up. And I looked at the patient. Patient wasn't looking right. So I quickly did a full assessment on the patient and everything. I now realized that the patient wasn't well at all. Ran to the doctor. Doctor said, okay, do this, that, and that. Did it and everything. Then they rushed the patient for an MRI. And everything, so we tried to settle the patient and everything. Anyway, send patient for MRI. So when when that was all done, we transferred the patient and everything. And I called the girl to the side. Goes, so I was kind of like pushed to ask her, like, how long has she been a nurse and everything. Oh, the next thing that came out of her mouth was, oh, how dare me ask her how long she's trained for, how long she's trained for. And after all, I'm an agency nurse, she's a permanent staff. And I lost it with her. Because if that patient had died, or if there becomes a secondary injury, apart from what the patient came in with, we'd have to answer for it.
Of course. So in that situation, in that scenario, would you just say that a lot of our people from back home, we carry our pride? Because obviously back home, like if you're a nurse, like you're next to the doctor, basically, you're next to it. So we are seen as very high up in the hierarchy in hospitals. So do you think that a lot of us from back home carry that pride, or them from back home? I'll say us because I came from back home. Do you think pride is an issue?
Yes, pride is an issue. And another thing, we don't know how to own up to our mistakes.
Accountability.
Accountability, exactly. And over here, we're actually trained to opt for, say, oh, yes, I did this wrong. Because the learning curve there is that, oh, damn, I did this thing wrong. So, yeah, let me take whatever, telling off or whatever,
from
and then later on they'll send you to training, and then you understand, because it's a learning curve. Nobody knows. Even when you come out of nursing school, you're qualified, you don't know anything till you start working on the shop floor. That's how it goes. But because they work previously in Nigeria or whichever country they've come from, well, let's stick with Nigeria. We're talking about Nigeria here, so this was what she said to me, and I was like, taken aback, like, you've just almost injured a patient. And I've not even shouted in the middle of the hot shop floor
to push you under the bus.
Exactly, I've not pushed you under the bus. I've called you to a corner and says, look, tell me what's going on. You understand? Maybe I can, in my mind, maybe I can cover for you. Not cover like bad behavior,
of course,
bad practice, but maybe at least help you. You understand? And this girl went off with me. Oh, I'm an agency nurse. I'm asking her this question. I'm asking her that. But the way she came across, I knew that she was a Japa. Then I now said, okay, fine. But unfortunately, she didn't know the relationship I had with the sisters there. So I now went to one of the sisters and I spoke to her. I goes, look, this is what happened, blah, blah, blah. Because, at the end of the day, you have to write reports.
Of course.
So I had to, as an agency nurse, I have to back myself up. So, and I told her what happened and everything. So she now says, okay, you write your report. She's going to get the girl to write the report as well. So fine. Then I looked at the report. Oh, obviously she was wrong, So then the sister now called me to corner and goes, oh, yes. Oh, do you know, we've had problems with these Nigerian nurses and everything.
Oh, Lord.
So I started laughing. She knew I was Nigerian, but she's always saying, oh, you're different. I must stop saying I'm different. We're all the same. We're all Nigerian. But she's always teasing me that I'm always different. So we just had this banter going all the time. So that's really dangerous, though. It's really dangerous. So because she had just as much experience as I have, but she was a permanent staff and she was one of the senior sisters. So she goes, yes, that's why I don't want to work with these Nigerians, especially these ones that have just come over and they just recruited them, and and they don't know what they're doing, and she went off and everything. So we laughed about it, but that kind of nervous.
But in that scenario, do you think that it's a case of she didn't have that training back home?
No, I think, the thing is, things have really, really changed back home.
Exactly.
Yeah. In the olden days, I think everything was, the right way. I say this because I had relatives, and I'm sure you must have all come across relatives who were trained back in the day, and they worked well and run. Our hospitals used to be very good back in the day. You understand? I think where the system has eroded in Nigeria,
it's affected everything else.
It's affected everything else. You understand? I mean, I've worked with somebody that didn't even know what a blood pressure machine was. And I had to show her, but she did not have the humility to come and ask that, I don't know where the machine is. Can you show me where it is? Or can you show me how it works? She didn't have the humility to do that. So when she eventually figured where the machine was, she didn't know how to turn on the machine. She didn't know what to do. And I stood there and with this person.
Sorry, I think you cut out just now. You said you stood. Sorry, because guys were recording remotely. So you said you stood there, but I didn't hear the rest of what you said.
Yeah, I stood there and watched her. You understand? And she didn't have the humility to actually ask how the machine works if somebody could help her. And and it's sort of the attitude, the aura she'd been giving up. I took myself away from there because I'd been burnt before by, trying to help, and I'd been shouted at, by, I thought, what, figure it out yourself. I'm an agency nurse, And I know sometimes it comes across as it's not very nice. You should be supportive of your colleagues. Yes, if your colleagues are receptive to the help you're giving, that's a different thing altogether.
I think you're even jumping one. You're saying if they're receptive, if they even want to first of all acknowledge. That's the first step. You've got to acknowledge that you messed up or you don't know before somebody can even start giving you any support. So this is scary. So that's someone that we expect to be fully trained up to a certain standard. So let's now even go further and talk about this. The people, the healthcare, I think they're called healthcare assistants. I don't even know.
Healthcare assistants, yeah.
Yeah. So let's talk about this particular case, and that's why we're recording this. I read that she'd only been in the job for 6 days.
Yeah, for 6 days, yeah.
So that's scary.
I'm sorry, personally,
the agency.
If she was on my ward, or if I was running a shift and I had somebody 6 days, I would not give her a patient like that.
So I think but was that even in a hospital? Was that in a care home?
No, I think it was it was either a care home or in the community. He had gone to the house or in a care home, something like that. But it wasn't in a hospital setting.
So Emily, I think that the first step is people have to be held accountable. The agencies have to be held accountable.
Yeah.
Because they're just taking people and just giving them jobs.
Exactly.
To care for vulnerable people.
Exactly.
And that's scary.
Yeah, it is scary. I mean, back in the day when I first started nursing, I used to like community nurses. So community nurses, when you go to people's houses to look after them, like that girl was doing, you go and look after them. But because I was qualified, I wouldn't be doing the washing and the bathing and everything. I'd be doing things like wound care, giving medication, filling notes, making sure the patient is safe, is cared for, and everything. Whereas the healthcare assistant at the community, as that lady was doing, go in and bathe them, make sure they have something to eat and stuff like that. So you can see the difference. But what I found was it just used to take a lot out of me, because if you go to a patient that has bilateral wounds and you're dressing the wounds, it takes time. So most of the time I was always exhausted after a day shift, 2 shifts, because you're driving around London, not the whole of London, but you're giving a certain area. So you're just driving around and going from door to door and stuff like that, So after a while, I just thought, I can't do this anymore. As much as I like my job, so I'd go back to accident and emergency, so I returned back to the hospital. But I have worked with these people before, and sometimes they don't give them enough time to look after these patients as well. So when everybody comes to work in the morning, everybody gets allocated. Then they might say to the healthcare assistant, I'm just making an example. You've got 10 patients, right? Well, those 10 patients, you probably have to wash 5 of those patients, right? And you have to watch 5 of these patients, and you've only got 10 minutes per patient, because you have to travel in between. So, and then some of them have to go twice a day. Some of them have to go once during lunchtime, and sometimes in the evening to go put them to bed and something like that. So, it just depends on, what the schedule is for the patients on your list. So you now find out that some of them don't have enough time. So they go in there, rush in and out, and, even when they make them a cup of tea, they practically throw it at the patient. Oh, here's a cup of tea, here's the sandwich, da, 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 da. And patients are like confused, like, who is this? And another thing is we also, what I found out with some of these healthcare assistants, even in a hospital when I work, they speak on the shop floor, they speak in the language. And I've had to say to them, do you mind not speaking your language on the shop floor? I've had somebody actually have an argument with me that I was bullying them. And my question was, why am I bullying you? Oh, I told her not to speak her language. I go, yeah, damn right, I told you not to speak your language. Put it this way, you're talking to a confused old white lady or white man, right? Or an English person, West Indian, or somebody like who's lived here all their lives.
Of course.
Right? Who only speaks English, and you're speaking your language and doing things. How they so sure that you're not talking about them?
Yeah.
You make them feel insecure, not safe, because they don't understand what's going on. So they're going to fight back, and if some of them have dementia, but they recognize the fact that you're not speaking a language that they understand.
So are they speaking to the patients, or are they talking to each other?
No, they just talk. Some of them they just talk
on the job.
Yes, if you have 2 healthcare assistants, they might be talking to themselves,
to each other,
because they don't want the patient to understand what they're saying. They start speaking in their language. And even I find that very offensive, is because I don't speak a Nigerian language. I understand the Nigerian language, but I don't speak fluently like some people do. So when I'm in the midst of in a group where people are speaking a certain language, I come to like, so look, I don't understand what you're saying. So that I expect them common sense to speak English, so I'd understand what they're saying.
And you're even Nigerian.
Yes, exactly.
So imagine someone.
Yes, exactly like you said, I'm Nigerian. So imagine a foreign person, not even foreign, they're English. You're in the country, they're English. You're speaking your language, and you're doing things for them, and you're speaking your language at the same time. It's so rude, and it's very unfair.
So I think let me just ask you. Let's say. So I think for me, the first thing, because I know quite a few people who've come from Nigeria and who were doing healthcare assistant jobs.
Yeah.
I don't know any of them who was doing anything in the health sector before they got here.
Yeah.
Because I feel like this woman, I don't know her, but if she'd only been in the job for 6 days, what I watched was horrific, right?
It was.
She seemed like somebody who was, I don't know whether it's anger, frustration, or wickedness. Do you understand? The emotions are my guesses are plenty. What if, let's say you were a health minister now, and they gave you this issue of Japa health? I'm talking about health. Let's talk about healthcare assistants, because that's why we started having this conversation.
Yeah.
And so let's say you were a health minister, and you were told to deal with this issue of Japa healthcare assistants. What safeguards would you put in place?
Oh, there's just so many safeguards.
So just throw out some. What are what safeguards would you put? Because this could be anybody's. This could happen to anybody's mother, or us, or us.
87-year-old mother. It could be my mother.
It could be me if I had an accident tomorrow.
Exactly.
Yeah. So what would you put in place?
So I'm not really that good on safeguarding, but as a typical nurse, things that I do would be, I mean, they do train them, but they don't train them very well. But I would say if she hadn't gotten training, the type of not training for, okay, we'll call it a mandatory training. So they've got their basic training from Nigeria, or when they come here, they just do a quick, this is how you do it. I'd be forced to make sure that they have the mandatory training. Right? Now, every clinician and every healthcare assistant, and it's always in place that everybody has mandatory training, right? That's number one. And then secondly, for somebody who has been only at this job for 6 days, she'd have to work with a senior person, a senior healthcare assistant.
Absolutely.
Yes. And give her a shorter list so that she doesn't have to rush and she has to do her job properly, right? And always be supervised till you're completely confident that she can work on her own. And then that way you gradually increase her list. And another thing is that because we're so short-staffed, these lists are sometimes are very unrealistically long. You understand? So reduce the list and let people do what they're capable of doing.
Okay.
And also, I mean, it's not very nice to have cameras in the house, but I was quite glad that they put the cameras.
Oh my God! Can you imagine if there were no cameras?
She deny everything.
Yeah, of course.
Yes, she deny everything. Yes.
So I think sorry, go ahead.
And also, even though she somebody like that to work with to be supervised, I'd say whoever the senior nurse is or senior
agency person,
yes, needs to be able to drop in as well and not just leave them to it. Now, yes, the NHS at the end of the day, they don't have money. We always know when they do their budgets and everything, they always seem to take away from the NHS, the health industry and the education system and put it into somewhere else. So we're always, on the negative, financially as well, to not being able to employ the people that we need to employ, and things like, and constant testing of these people, I don't want to keep on saying. I think people like this, some strange people from a different universe, from these japads, these COS japads. You understand? And it's just putting it into. It's not like you don't get to a state where you trust them, but make sure that they are aware that they're being watched. So whatever you do, you're being watched. So make sure you're very careful in what you do and you do your job. And if you're tired, you can't do your job. Don't do your job. As far as I'm concerned, some of these people, they do shifts, they work overtime.
Yeah.
So as far as I'm concerned, back in the day, the Royal College of Nursing put into place that a nurse shouldn't do more than certain shifts. So like if you do like nights, you can't do like 5 straight nights. You need to do, I think it's either 2 or 3 nights, then you break it, then you understand, you do another 2 or 3, then you break it. So if I was her supervisor or the recruitment agency, wherever she come from, I'd make sure that because she is new, I'd make sure that she didn't do more than so many shifts in a week.
Yeah.
But the problem also is there's some backhand nursing homes or recruiters that give them the extra shifts.
Emily, that is what I so there are the ones that are with the NHS and the hospitals send them, and those are different. Then we have the rogue agencies. For me, those are even the ones that I think that I am more cross with, because I don't think they do the checks. I'm not saying that every healthcare person must have a health training, must have a background in medicine, right? Because obviously anybody can, we have transferable skills. So, but these agencies, you see somebody, for example, this person is a banker. They come to the UK, they register with your agency. They give you their CV. You can see, maybe the CVs are also doctored, I don't know. But the agencies, these people, that this person is going to be their first time doing this. You just take them, you give them shifts, and they're caring for vulnerable people. Do you know that when I came to the UK, because that was one of the things, when I came to the UK and I was studying, I thought, let me go do a part-time job. Emily, I had to do, this was many, 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 many years ago. I had to do a training. Emily, do you know I ran out of the home I was supposed to be doing my I tell everybody the story. I ran out because I think they were teaching me how to lift an old lady and brush her teeth and wash her dentures. It's not for everybody.
It's not for everybody.
I ran and I left my train. I didn't finish the training. I didn't take the certificate. I didn't take my money's worth. I ran away. It's not for everybody.
So you don't have to do it. Exactly.
It's not for everybody.
It's not for you.
So exactly. I feel that there should be a crack that I don't know, but there really needs to be a crackdown.
I agree with you, and I think there should be a crackdown on these rogue agencies. CQC is one of our governing bodies. They go to hospitals, they go to homes and nursing homes
to check
respite homes and stuff like that. So I think they should really, really kind of like start cracking the whip now, because there are just so many rogue agencies out there.
just churning out shifts to people who anybody that will.
Exactly.
And I also feel so. I also feel sorry for the. I mean, I know people may not agree, but sometimes I have sympathy for the people that are doing that job. I know that you said that they were not, nobody forced them, but I beg to disagree. I feel
it's a hard.
Yeah.
I'd interject that it's a very, very difficult job. I mean, I remember when I was training, an Irish nurse, she was my mentor. She said to me, she goes, Emily, when you're doing this job, as much as you like this job and you feel fulfilled and everything, you're going to get to a stage, it's called burnout. Once you start working for money, and that empathy, that passion
for human,
step back, leave it. And I came to a stage where I had burnout. But the thing for me was, I'd say I was one of the lucky ones. I stepped back and I went into IT. No. Before that, I went and did my midwifery training, and I even got more burnouts after my midwifery training because it was so stressful and everything. And I thought, you know what, I've had it.
With the whole medical thing.
With the whole medical thing, I'm not doing it anymore. I don't care. I want to fill shifts. I want to work. I fill shifts. I want to work in McDonald's. I don't care.
Anything away from that.
Anything away from clinicals. But I was so lucky, and this is why we all have different lucks. I was so lucky. I now fell into IT, and that was how I became, an IT person, so I do an IT. So I was lucky. So not everybody's lucky like that. But what I'm saying is, in context, that when you get to that stage where you can't do it anymore, or even before you do, you look at it, goes, nah, after the training, goes, nah, this isn't for me. Go look for something else.
Yeah, but Emily, let me play devil's advocate again. I'm piggybacking off what you just said. Is that even a word? Yeah, I think so.
Yeah.
Off what you just said. Your mentor said to you, when you start doing it for money, it's not for you. But we know that a large percent, I don't want to even give percentages before they come from my head, but I know that a very, 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 very large percentage of the Japa people are working for money. They're not doing that job because they want to do that job.
No, I agree with you.
You know what I mean? So how do we get around? So because we know that issue of they don't have the option, because you need that COS. These are the people that are going to give you that COS to stay here. So we don't have the option of thinking, no, I'm not feeling it anymore. It's not for me. They're there. The issue is now on making sure that, okay, they're there, even if they're working for money, that they're not putting people's lives in danger.
Okay, I'll tell you something else. The problem with that is, number one, let's just deal with it. Number one, because we have that mindset of converting the pounds to naira. You see them working all these shifts because they are converting. Now, why are they converting? They sold their land, they sold their houses, they sold their cars and everything. So they're trying to fill that gap of making up for what they've lost coming over here, right? So they're just doing anything in terms of, yes, okay, they do healthcare assistant in the care world and everything, right? But the other things that they're COS for everything. They're COS for everything. But I know with the health industry, that was one of the reasons why they opened the borders for everybody to come in with the healthcare. Because
of course,
we don't have enough staff and everything. I agree, right? But you see, the thing is, it's a lot of things are common sense, right? If you come with your husband and or you come with the husband, man comes with his wife, and you find out. I mean, okay, where I'm going with this? A lot of them have come over. They've brought 3 kids with them, right? You're going, but they've come with the wrong information. You've told them when you get to England, you get free education, you get free healthcare, you get free this, you collect income support and everything. So they believe that when they get here, as they get here, open the door, they start giving them money and everything. Then they can do. You understand? So now, because they've come through rogue agencies as well, and they've got the wrong information, when they come here, they kind of like, oh, damn.
Yeah.
You understand?
Yeah. We're here and so, now look at what's happening to us.
Exactly. You can't go back. You can't go back. Or what will people say back home? You understand? Now, if you think about our parents, when they first came here back in the day, in the 50s, 40s, 60s, some who had children, they left the children for their mothers or their grandparents or whatever, and they came here did whatever they had to do and go back. I know these are different times, don't get me wrong. But I've seen people coming over here with 5 kids, and I'm thinking, why would you do that? But they've come with the wrong information. So another thing where I'm going with this is that we don't do our own research.
Absolutely.
You always say, oh, how do they do it? But they do like, okay, do it for me. They throw money at everything. Go and do your research yourself.
And then,
don't expect people to tell you this is how they do it over there. This how do. The internet is for everybody.
No, we do not do that one. We don't do.
Now come here. When these people now come here, it's a different ball game altogether. And they say, oh, my agent. What you need an agent for? My agent told me this. My agent told those ones are not there to collect their money.
It's a culture shock when they get there. Emily, to think in their defense.
It's okay.
In their defense, many of them wouldn't be here if the country was better.
Oh yes, even we who were born here, here, or even came after education to do our master's or our first degree or whatever, we would not be here. I got taken home as a child when my father finished his master's. Now, Nigerians have to get him back, and the first thing my parents did was, let's not get caught in it and send us all back. But things were still okay then, you had the money, you could still buy a ticket, and then, the kids sort themselves out, they're born here and everything. So that was okay. If Nigeria was good, even as of now, some of us here at our age that will not even be here. Because why would you want to be in a country where it's cold, it's hostile, there's, you're paying bills, an average 1-bedroom flat. I'm not talking about 3-4. An average 1-bedroom flat you rent in this country, let's just say within London, is more than £1,000.
And you're not even going to rent a 1-bedroom flat with your husband and how many children? So you at least maybe have to. So let the blame first of all start with the Nigerian government, because I know so many people who are now doing these care jobs who had decent jobs. I don't think the UK is anybody's any right thinking person's dream life. So
I completely agree with you.
So the blame first of all starts with the Nigerian government. Then for me, I think also the rogue agencies are not helping, because Emily, what I fear will happen is this lady, I think she managed to dodge a prison sentence. Very soon, because now there's a precedent, the sentencing, and with the outcry and anger about this sentencing, if there's a similar case, that person is not going to just have a suspended sentence anymore.
Oh no,
they would. That person will have to.
Go down.
Yeah, because if that was my dad, I would be appealing the sentence. You cannot tell me anything.
Don't be surprised. Don't be surprised if this particular person is not appealing.
Yeah.
And I'll tell you why. I'll tell you one of the other reasons why she was given a light sentence as well. One of the reasons why she was given a light sentence was, and like you say, playing devil's advocate, but we hear it as clinicians, right? Oh, he's an old man, he was going to die anyway. Serious. Now, it's not nice to say, but it's the reality. I mean, we've had situations where a patient is ill in the late 80s or 90s, and they say, oh, let's treat the patient conservatively. So in the back, what if you read between the lines, what they're actually saying is that, why was this person's old anyway? They're gonna die anyway. And they don't say it.
They don't say it, but that's such a bad way. That's such a bad way of thinking.
Exactly.
Because you're opening Pandora's box. This person, he was gonna die anyway. But did he tell you that he wanted to be treated that way? I don't know.
Exactly.
I don't know the link between her treatment and his passing. I don't know, but whatever it is, even if there was no link, the way he was treated was so bad. Nobody should have to go through that. So even me with my empathy and compassion for people, people who have to leave Nigeria to come here, and I understand the grafting and this woman, to me, should have gone to prison. I'm sorry, because she should have gone to prison.
Excuse me, she should have done a minimum of 5 years. I'm sorry.
Listen,
yes.
I agree with you. The agency or whoever hired her, they should have looked into their procedure. What did you check? What was her CV? What training did you give her?
Yeah.
It's 6 days in. She's 6 days in, and she's caring for a vulnerable old man.
Exactly.
So
Or
that
has dementia. Even if he didn't have dementia, he's an old person, vulnerable old person.
it
And you
was
treat
so
the person
bad.
like that. No,
I do
it's
not.
so
I couldn't.
sad.
Do you know? I couldn't watch that whole video in a stretch. I had to
It's
cut.
sad.
I had to
It's hard.
keep stopping because when he was, there were times that he was, he was grown. Oh my God, no way.
No,
So
it's hard.
we've established that we need to the blame first of all starts with our country,
Yes.
our government,
Yeah.
which is a joke by the way. And then these agencies, rogue agencies, and even if they're not rogue agencies, the NHS is, like you said, overburdened. So maybe the level of supervision, if she was coming straight from, I don't know, if she was a hospital or whatever, staff, the level of supervision, I don't think it was there. She's 6 days
No, it
in.
wasn't there. It wasn't there. It was not there. All they were looking at was the council. So the guy was at, I think he was at home in his own house. But if he wasn't even in his house, he was in a nursing home. So what happens? I think the council pays some money to the agency / it comes to the hospital. Anyway, there's a different budget thing behind that.
Yeah.
Right? So, but something to do with the council as well.
Okay.
So all the agency is looking at is the money that comes in. So assuming that for each patient you get, and you just make an assumption.
Yeah.
Assuming the healthcare assistant says, oh, okay, they're paying the healthcare assistant maybe maybe £15, right? An hour. On top of that £15, the agency will probably get about £80 to £100.
Okay.
I'm making that example. So do you see out of £100 that they pay them, they only give the healthcare assistant £15, right? So they're keeping all that other money.
Are you kidding me?
Yeah.
Really? That little is what the person that's suffering is going to get?
Yeah, for an hour. So for if the patient, if they're assigned maybe like for a week's care package. I'm making examples.
Yes.
Making a week's care package, say £500 for that week, right? So that £500, the carer will come, say Monday to Friday. But the care out of that £500 will say £100 a day, right? We only get for that 1 hour, we only get maybe £15. The maximum we will get between, I think the minimum wage, I don't know if the minimum wage is and the age thing and everything, we'll probably get only about £14 to £15 an hour. Right? Then the rest, the agency keeps it. So the agency will probably keep about £80, right? So if it's based on £100. But what I'm trying to say is that you see how little they get. So if you think about it, on top of that £15, so if you did maybe they give them 5-hour shift a day, right? That 5-hour shift, 15 times 5,
75.
75. Now on that 75 times 5 days, right? Then the taxman comes and takes his own share. Then your NI come and takes your own share. Yeah. These people are probably going home. I'm making assumptions here.
That's slavery, my dear. Yeah. And slavery has been abolished.
Exactly. So these people end up taking more shifts and more shifts. I have seen people do night shifts and go to day shifts. I'm thinking, are you serious?
How are you? It's sad. It's really it's frustrating to even hear because they have to work to pay the rent and all that. Yes. But then the flip side is they're putting people in danger. I think the only way to deal with this, because we're going to round up soon, the only way to deal with this is making sure that agencies are doing their due diligence, agencies and hospitals, making sure that training is given over a sustained period. And like you said, supervision. You don't just tell the person, oh yeah, go to Mr. Oliver's house. Supervision for a significant period of time until you're comfortable. And like you said, cameras, if possible, for those homes or, even if they're private clients who can afford it.
Yeah.
And crackdowns on these agencies. These agencies are thieves.
Yeah, they are.
They're thieves. So
it's sorry, I'll let you finish.
No, I've finished. I'm just it's annoying.
I mean, back in the day, I always said to myself and some friends were saying, "Oh, we'll set up a nursing agency so we can make money and everything." I mean, I never got around to it because I I enjoy working hands-on as a person, hands-on anyway. But there's a lot of things to setting up a nursing agency or recruitment agency. It's not just only getting the people to go out there to work. It's also the risk of getting
sued.
People who just want, like you said, not everybody works for the passion. You have to work for money. You have to pay the bills. Like I say, passion doesn't pay the bills.
Yeah, absolutely.
But also, you have to have a bit of feeling, empathy when you go and look after these people. So, if you come to me as an agency and say, yes, I've got this experience, it all looks good on paper, but who is supervising them? So the recruitment agencies just sit in their offices and dish out all these shifts and everything, and they don't supervise them on the shop floor in terms of dropping in to see what they're doing, to check their notes, to speak to the patients or to speak to the families and stuff like that. As far as they're concerned, no complaints comes out of that particular patient.
And that's it, yeah. And Emily, another thing I was thinking was, our people, we are usually nurturing, because we all have parents from how our community is back home. We have parents where we have, we are nurturers, we care for people. Somebody's auntie has lived with them or their grandmother or whatever. But when they when they now come here and they're having to do these jobs because of the COS situation and to raise and to get money, then at some point that empathy, I guess if you have to see 10 patients in 5 hours I do all these tasks, then sometimes it's difficult to juggle. So we come back to the agencies also allocating shifts that are reasonable.
Yes, the agencies are equally responsible because if I run an agency and I see a newbie, even though if it looks good on paper, when you speak to them, you know that this person does not have experience.
Yeah.
And it's not by saying I've worked at this home or that home. Check the experience that they say they have. Check it. You understand? Check it. Some of these people don't even know how to change diapers. I mean, they think, okay, fine. You just change it, whip it off and everything, but you've not even given the patient a good clean.
Wash.
You just change it, a good wash. You just change the diapers and just put something else. And I am thinking, but wait, it's you yourself, when you go to toilet, you wash yourself and everything, clean yourself, you wash yourself and put on clean pants. So why would you put on, without cleaning them or not even doing it nicely?
Do you think that, Emily, just as we're talking, do you think that, because I'm going back to this thing, because I remember saying that the people don't have to have like a medical background or whatever. Do you think that would actually help someone who has been, do you understand what I'm saying? Because I keep talking about bankers, because I do, there's a reason why I keep mentioning bankers. Do you feel that maybe one of the ways to deal with this situation is for the agencies to only, or for I'm still seeing you as health minister, because we must make this money. You must be health minister. So I'm just putting you as health minister. Do you think that that's one of the, because I'm just thinking about it.
Okay, because I'll tell you the difference here. In America, you have different stages of nursing. Okay. And you see the difference why it works in America, right? I'm not saying that they don't maltreat the patients, but I'll tell you why it works. In America, you have CNAs, right? Certified Nursing Assistants, right? Okay. They're like care assistants, right? Then you have the LPNs. The LPNs are licensed practical nurses, right? So they're like they're qualified to do certain things. The clinician, but there's certain things that they don't do. Then you have the registered nurses, right?
Okay.
Which is myself, right? Then on top of the registered nurses, then you have your hierarchy as well, right? Now, in America, for those CNAs, they actually go to school. They go to school for, I think, 6 months to 1 year.
This is what I'm saying.
Yeah. I think they should actually sit in a classroom. When I say sit in a classroom, not for 1 day or 2 days.
Practical. Yes.
You must be in the classroom for a minimum of 3 months. I'm sorry to say.
Proper training. Yeah.
Yes.
Because Emily, even if you're doing it for the money, that training will equip you with skills that you must implement. So as long as you're looking after the person well, if you're not hugging them or cuddling them, that's irrelevant. But if you're looking after the person well and doing what you're supposed to do, that we're good.
Yes, exactly.
We're good. Exactly. But to expect somebody who was rocking life in Lagos to just come here and a week later they're cleaning an old vulnerable person who obviously is challenging, it's not gonna, these things are gonna keep happening.
No.
And if there was no camera, do you know how many other we're talking about this one incident that we know?
Do you know what they do to them? You know? And it's so sad that we don't even trust people to look after our elderly patients. I mean, I always say to myself, even though I'm a woman of a certain age, I do say that I like to see myself as young, but we're all getting on.
Well, we're all heading there.
We all get old one day, So, and I say and I think, oh my God, if for any reason, I mean, the good thing about us Nigerians or Africans, we don't necessarily, some of them do, but we don't necessarily put our parents in homes.
Yes.
But things are changing now. You understand? So you do see one or two people in the nursing home. And I'm just thinking, if that was my mother in a nursing home, would I trust anybody to look after my mother?
And treat her with dignity.
Exactly. But the thing is, you still have to do your work. So you have to put her somewhere or put him somewhere to be looked after while you can go out to work, to live your own life as well. And it's so sad that we have a system like that here. And other people, the system was actually built for their own people, not built for us.
Yeah.
Right?
Yeah.
Now, when I lived in the Middle East, when the patients go to hospital, they take their maids with them. Or their butlers or whatever, right? So they care for them, right? Now, that's the way the system here is there. But over here, even if your parents are in hospital or your elderly person is in hospital, you can have them come and visit you, but you can't
care for them.
Sleep or care for them, if you see what I mean. And even you can come there to care for them, but only with certain... There's a limit.
Of course.
You understand? So our society here is not built like that. Whereas back home in Nigeria, which is similar to what they do in the Middle East,
of course,
you can actually go to hospital and
put
somebody there to help yourself. Yeah. So we're not, even though we have elderly parents and relatives at home, we don't necessarily look after them. We always employ somebody to look after them, and we keep an eye on them. So we don't necessarily get all these bad treatment, or at least you can catch it early. If at all it's there. You understand? Like if you're not feeding the elderly person, giving their food early enough, or
all those things.
You understand? So if you're paying for somebody to look after them, why didn't you give her water to drink? Oh, she didn't want water, so I don't give it. But you can always catch it early.
Yeah.
It says, right, put your foot down. You must give her water to drink or something to eat at a particular time. But whereas where I'm going with this is that because we're not used to that, when we come over here, we look at this and goes, oh, anyway, I'll just do the job and go home. But there's more to it here. So you can't just do the job and go home here. You need to actually take responsibility for what you're doing. But the thing is, how many people are you going to take responsibility for here? We're short-staffed already. But when there's too much room for mistake, and people not taking accountability, and people pushing the blame. Now, number one, those rogue agents, there's some really, really good agencies out there. Those rogue agencies, they need to close them down or put them on timeout or whatever they usually do to them, and reduce the amount of people that they take from those agencies. And of course, again, the hospitals are equally responsible because they are so financially strapped. They go for cheap agencies, and those cheap agencies are giving you bad staff.
Yeah.
And I'm not saying that the staff are bad, but staff that will come in with. Oh God, back in the day, I mean, I used to know people, not me personally, I've heard of people using other people's PIN numbers to work. I mean, it doesn't happen anymore, but you still get one or two rogue people like that, you understand? So they have to be really, really careful. Just like in England here, when you want to work with the armed forces, or you work with any sort of, they do security checks.
Of course.
They do security checks, and they're not, it's not nothing like DBS. If you have to do security checks, then these people will probably they'll think more about what they're doing.
They'll think more about what they're doing, and also with this, what's annoying to me is that this case about this woman was the reason why we decided that we must do this today. I wish that they had set a very clear precedent for any future situations. Because that thing that happened, no. If she had, because our people, we love our freedom. First of all, she had gone to prison for whatever amount of time. Trust me.
Everybody will sit up.
Trust me, everybody will sit up. Then the agency, all of them, because they're money focused. If she was an agency staff, the agency needs to be bank. If I was the family, I would. If it was my father.
Yeah. Unfortunately, we don't have a suing culture in this country.
Yeah, exactly.
That happens when you sue the person. You sue the agency.
Sue
they
the
close down
agency.
straight.
Yeah, sue the agency. Sue the council that use the agency.
Yes.
Sue everybody.
Yes, I'm not saying, I'm not saying that we should have a suing culture, but sometimes we need to teach us a bit of a lesson here, because if the agency was going to be sued millions,
trust me, they would be careful.
They'll think twice.
Yeah, they'll be careful.
Think twice and just employed anybody.
Yeah, they will be
so
careful.
Everybody is responsible for that bad behavior.
Yeah, everybody, starting from your government to the agencies,
from our government,
to even the like you even said, even the individuals, like, because like you said, we're going back to what you were saying, no one forced them. And I know that I played devil's advocate and I said, but really, truly, like I told you, I could not finish my training. It's just not, I couldn't do it.
Yeah.
I couldn't do it. I just could not do it. So if you see that it's not for you, rather than go and put somebody's father, mother, child at risk of harm from your behavior, find something else to do.
Find something else.
Yeah.
I know people who have come to this country, they haven't gotten jobs. They do hairdressing, and I know it's all, you need to be a COS so that you can get your stay. I understand that. But before you come, learn a trade. If you have to learn a trade, okay, it's easier said than done. But, you haven't just woken up one morning and goes, oh, I'm going to England. You've planned it. Well, I'd assume they've planned it over the years.
Before
in a year or 2 years time. So, that's enough time for you to learn something. Tailoring, hairdressing, there are lots of things that you could learn.
But
as simple examples.
Like to even round up, what I would say is that our people, I love our people. We're hardworking.
Very hardworking.
We commit to it, but we also let me use this phrase, we get mind. And for people who don't understand what I'm saying, our people, we fear. We don't have fear. I would be petrified. I would be scared to care for an old person if I wasn't well equipped.
Do you know, we are so bold that if you go to the coldest part of the world, there is a Nigerian there.
Yeah.
And I kid you not, is married to one of these, it's where these Eskimos stay, right? So you can imagine how cold it is. If you turn off your engine at the beginning of winter, so you turn off your car engine, you go back the next morning, you can't start your car. You have to wait till after winter to start your car.
But Emily, the thing,
right? I hear?
Yeah, there is a Nigerian there. But for me, when I say that we have mind, we're strong. You're strong. You know that you don't have training in this, you don't have any experience in this, yet somehow you manage to come here. Somehow you get serious and you go to somebody's house and you start caring, or you go and you start caring for a vulnerable person.
I know.
Without fear. Fear will not grieve me.
And this is probably why we should go and use the American system.
Absolutely.
Like the levels of nursing.
Absolutely.
We have it here. They do NVQ and everything. But I don't know how they do it, but they do it here. But as far as I'm concerned, if you're going to come in and do the COS, then the minimum training you should get is 3 months. I'm sorry to say, yes, you don't have the time, but tough.
I think that they can give them something like a temporary COS.
Yes, exactly, a temporary COS.
While you finish complete.
So you do your 3 months, your minimum of 3 months or 6 months, depends on what you
want to do.
Yeah, you understand. You do your 3 months, and then obviously you're under supervision and everything, and then if you pass it, then you can start going out to work, and still for that at least first 6 months you're on complete probation.
Emily, I think we've cracked it. We need to sell that. We need to bottle this idea up. We're laughing now, but I agree with you.
It's very serious.
I agree with you. I totally agree with you. Mandatory whatever training. I know, yes, COS. So that's why I suggested the interim COS so that they can be here.
3 months.
Yeah.
So they can go and do their training for 3 months and sit down in a class and do their training for 3 months, and then they're under supervision for those 3 to 6 months, and they're on probation. So they're under supervision and probation for their first 6 months of working.
Yeah.
And the agency takes responsibility for that as well.
Yeah, absolutely.
They should sign a contract. We should sign a contract with the family that they're responsible for this. You see, once everybody starts signing something and becomes legitimate in terms of legalities involved in it, I think a lot of people will sit up.
Yeah, absolutely. Oh my God, Emily. I think with this I like how we're ending this thing, because this thing that you just said, I so buy into it. I so buy into the training, because that will help weed out, because some people, if it's not your thing, after some time, maybe after 1 month of the training, you drop out, like me that didn't complete my own.
Exactly, yes.
Emily, it's been fantastic talking to you.
Thank you very much.
I am glad that we finally got around to listen. They will come for us, so some people will come for us when they listen to this podcast. They'll say where, but I don't care. I don't care. We're speaking facts. Yeah, we're speaking facts. Yeah, it's that simple. So I want to thank you so much for taking out time, for being patient with me, because we've tried to arrange this thing up and down.
Yeah.
But your life has been busy and mine has been chaotic.
Yeah.
So I want to thank you. I thank you again for your service. I'm serious. NHS. I don't play with the NHS, so you see my post on Facebook. I thank you for everything. I thank you for taking out time and for just being frank, because we're Nigerian. We love our brothers and sisters, but still, we've got to speak facts.
Well, yes.
Yeah.
You've got to say the truth.
Absolutely.
Yeah,
absolutely. Thank you so much. Okay, so that's fine. So for everyone that's listened to this podcast, let me know what your thoughts are. Good, bad, whatever. Some of you will not comment, so you will now be sending me WhatsApp messages, blasting me or thanking me, whatever your situation is. Comment, listen, let me know what your thoughts are. Please share with your friends, in your groups, wherever. Until next time, I'm sending you guys off with peace, love. Take care of yourselves, and let's take care of each other. Bye, everybody.
Yes, of course. Thank you. Bye.
Bye.